All right, welcome everyone to another deep dive. Today we're taking a closer look at something called localized acute bacterial lymphadenitis. Now, I know that might sound a bit intimidating, but bear with me. For our medical microbiologists out there, this is just a fancy way of saying swollen lymph nodes, right? But specifically, the kind caused by bacteria. And you might be surprised to learn that there's actually a lot of debate about how to best treat these cases. So to help us break it all down, we have a true expert in infectious diseases joining us today. They're going to walk us through the latest guidelines and help us all figure out what really matters in practice.
Well, thanks for having me. I'm happy to be here to shed some light on this common condition. It really is something that a lot of people misunderstand.
I think that's a great place to start, actually.
Yeah.
So can you give us a quick, refresher on what localized acute bacterial lymphadenitis actually is?
Sure. So we're basically talking about an inflammation of the lymph nodes. And as the name suggests, it's caused by bacteria. The localized part means it's affecting a specific area. And acute means it comes on quickly, and usually it's self-limiting. So we're talking about those swollen glands that you might see in the neck or armpit or groin.
Okay, so not just any swollen lymph node. It's got to be caused by bacteria. But how do we even know if it's bacteria causing the problem in the first place? What are some of those red flags that tell us we need to investigate further?
So when you have a patient come in with swollen lymph nodes, there are a few key things that point towards a bacterial cause. So first off, the lymph node itself is usually going to be enlarged and tender, and the skin over it will probably be red and warm to the touch. Sometimes you even see some drainage or cellulitis, which is a skin infection.
Oh, wow. So it really looks as bad as it feels. So if it looks angry and it feels like a hot, tender lump, that's a pretty good sign that it might be bacterial.
Exactly. And another thing to look for is if the swelling is only on one side of the body. We call that unilateral involvement. And if you press on the node and it feels like it's filled with fluid that's called fluctuance, that's another sign that we might be dealing with a bacterial infection.
Okay, that makes sense. But I'm sure there are other things that can cause similar symptoms, right?
Oh, absolutely. We always have to consider other possibilities like viral infections. Actually, viral infections are the most common cause of lymphadenitis overall. So things like mononucleosis or even HIV can cause swollen lymph nodes too. That's why taking a thorough patient history and doing a good physical exam are so important. They really help us rule out other conditions.
That's a good point. So we've got a patient with swollen lymph nodes and we suspect it might be bacterial. What kind of lab tests do we typically run to confirm that suspicion?
Well, this is where things get interesting. The World Health Organization has these guidelines called AWARE, which focus on antibiotic stewardship. And they actually advise against routine microbiology testing for most of these cases.
No lab tests. Why not?
Well, the thinking is that most cases of localized acute bacterial lymphadenitis will actually resolve on their own, even without antibiotics. So sending off cultures and putting the patient through all those extra tests may not be the best way to go. It's all about using antibiotics responsibly, which is what AWARE is all about.
Okay, I see where you're going with this.
Yeah.
But I imagine there must be times when we do need to run some tests, right?
Of course. If the lymph node stays enlarged for more than 4 weeks, or if the patient just isn't getting better, then we need to investigate further. And if there are any red flags in their history, like if they've recently traveled or been exposed to someone with tuberculosis, for example, then we'd want to order specific tests to rule those things out.
So it's kind of a judgment call based on each individual patient. But let's say we do decide to go ahead with microbiology testing. What are some of the usual suspects we'd be looking for?
The most common ones you'll see are Staphylococcus aureus, and that includes MRSA, by the way. And then Streptococcus pyogenes. These are the culprits that show up most often. And it's all laid out in Table 9.1 of the AWARE guidelines. By the way, those guidelines are really a great resource to have handy.
It's a good tip. I'm assuming knowing these common bacteria helps us choose the right treatment, right?
It does, but before we jump into treatment, there's one other type of lab. It can be helpful, but again, it's not always necessary. An ultrasound can confirm that the lymph node is actually involved and tell us how big it is.
Yeah.
And it can even show us if there's an abscess forming.
So it gives us a window into what's happening inside the lymph node.
Exactly. But here's the catch. Ultrasound can't rule out cancer. So if we're concerned about something more serious like lymphoma, we'd need to do a biopsy to get a definitive answer.
That's a good point.
Yeah.
Okay, so we spent a good amount of time talking about diagnosis, but let's get to the heart of the matter. What about treatment? What's the game plan when it comes to managing localized acute bacterial lymphadenitis?
This is really where those AWARE guidelines shine. And the surprising thing is that most cases actually don't even need antibiotics.
Really? We can just wait and see what happens.
Yep. I know it sounds counterintuitive, but the body is pretty amazing at healing itself, especially if the infection is mild. Watchful waiting is often the best course of action. It's a core principle of antibiotic stewardship, only using antibiotics when they're absolutely necessary.
I bet that's something that resonates with our medical microbiology listeners. They're always thinking about antibiotic resistance. But how do we decide which patients are good candidates for this watchful waiting approach?
The key is to assess how severe the infection is. So if a patient has a high fever or a lot of pain, or if the lymph node is growing rapidly, those are all signs that we might need to step in with antibiotics.
So it's all about looking at the clinical picture as a whole. But let's say we do decide to go with antibiotics. What are our options and how do we choose the right one?
Well, the AWARE guidelines actually have a table that outlines the recommended antibiotics. It's table 9.2. And for adults, the usual suspects are amoxicillin, clavulanic acid, cephalexin, and cloxacillin.
I'm guessing the choice depends on a few different things, right?
You got it. Things like the severity of the infection, local resistance patterns, and even the patient's allergies. They all come into play when deciding which antibiotic to use.
Makes sense. Okay, so let's dive a little deeper into these options. What about dosages and duration of treatment? I know those are always important considerations.
Yeah, for sure. The table gives specific recommendations for both adults and children. For example, for adults, the typical dose of amoxicillin clavulanic acid is either 1 gram plus 200 milligrams intravenously every 8 hours, or 500 milligrams plus 125 milligrams orally every 8 hours. Cephalexin is usually given as 500 milligrams orally every 8 hours, and for cloxacillin, it's either 2 grams intravenously every 6 hours or 500 milligrams orally every 6 hours. The important thing is to follow those guidelines carefully to make sure the dosing is appropriate.
And what about the length of treatment? How long do we typically give these antibiotics for?
The AWARE guidelines actually recommend a 5-day course for most uncomplicated cases.
5 days? That seems pretty short.
I know, it might seem surprising, but studies have shown that 5 days is usually enough to take care of the infection. And remember, we want to use antibiotics judiciously to minimize the risk of resistance.
Right, of course. So I noticed something in Table 9.2. It mentions that cloxacillin and cephalexin have a narrower spectrum of activity compared to amoxicillin clavulanic acid. Can you explain what that means for our listeners?
Sure, so that just means that cloxacillin and cephalexin are effective against a smaller range of bacteria. Compared to amoxicillin clavulanic acid, however, they're often preferred for mild infections because they target those most likely culprits without wiping out a bunch of other bacteria unnecessarily.
So it's kind of like using a scalpel instead of a sledgehammer.
Exactly. It's all about choosing the right tool for the job.
Makes sense. And that brings us right back to the idea of antibiotic stewardship. It's not just about using less, it's about using them smarter.
That's exactly right. It's a really critical concept, especially for medical microbiologists who are on the front lines of this battle against antibiotic resistance.
Absolutely. We all have a part to play in that. I also noticed another interesting little detail on the table. It says that the oral liquid form of amoxicillin clavulanic acid needs to be refrigerated. Why is that?
Good catch. So that has to do with the clavulanic acid, which is part of this combination antibiotic. It helps protect the amoxicillin from being broken down by certain enzymes that bacteria produce. But clavulanic acid is sensitive to heat and moisture, so keeping it refrigerated helps to maintain its stability and make sure it stays effective.
So proper storage is really key to making sure the antibiotic actually works.
Exactly. It's a simple thing, but it often gets overlooked.
Okay, so we've talked a lot about the practical aspects of managing localized acute bacterial lymphadenitis. But I think it would be helpful to take a step back for a moment and talk about what's actually happening at a cellular level. Could you walk us through the pathophysiology of this condition?
Of course. So when bacteria get into the body, say through a cut in the skin, they can sometimes travel to nearby lymph nodes. Think of lymph nodes like tiny filters. They trap foreign invaders and then trigger an immune response.
So like the body's little security checkpoints.
Exactly. So when bacteria reach the lymph node, the immune system kicks into gear. White blood cells like neutrophils and macrophages rush to the scene, and they try to engulf and destroy those invaders. This leads to inflammation, which is what causes the lymph node to swell up and become tender and warm.
So it's like a little microscopic battle happening inside the lymph node.
That's a great way to put it. And most of the time, the body wins this battle and the infection goes away on its own. But sometimes the bacteria gain the upper hand, and that's when we need to step in with antibiotics.
That makes sense. Now let's zoom out a bit and talk about epidemiology. How common is localized acute bacterial lymphadenitis globally?
It's actually one of the most common reasons people seek medical care worldwide. It affects people of all ages, but it's particularly common in children. And while most cases are benign, it's important to remember that it can sometimes be a sign of something more serious.
So it's always important to keep those other possibilities in mind.
Absolutely. And the specific epidemiology can vary quite a bit depending on the region of the world and the population we're looking at. For example, in some parts of Africa, tuberculous lymphadenitis, which is caused by the same bacteria that causes tuberculosis, is a major problem. And in individuals with compromised immune systems, like those with HIV lymphadenitis, can be more frequent and more severe.
Wow. It's fascinating how the epidemiology can give us clues about the underlying causes and potential complications. Okay, let's circle back to the bacteria for a minute. We know Staphylococcus aureus and Streptococcus pyogenes are the most common culprits. But are there any other bacteria we need to be aware of?
While those two are definitely the heavy hitters, we can't forget about other possibilities, especially when the clinical presentation is a little unusual.
So if something doesn't quite add up, we need to think outside the box.
Exactly. For instance, if someone has a history of cat scratches, we need to consider Bartonella henselae, which causes cat scratch disease. And in patients with certain risk factors, like exposure to contaminated water, we might suspect unusual bacteria like Francisella tularensis, which causes tularemia.
This is where the expertise of a medical microbiologist really comes in handy. They can take all the pieces of the puzzle, the patient's history, the clinical presentation, the lab results, and put it all together to make an accurate diagnosis.
Absolutely. It's like detective work trying to figure out who the culprit is and how to best neutralize them.
I love that analogy. Speaking of putting your detective skills to the test, I've prepared a few exam-style questions to see how much our listeners have absorbed. Are you ready for a little pop quiz?
Bring it on. Yeah, let's do it.
Okay, first question. A 5-year-old child comes in with a swollen, tender lymph node right under their jaw. It's red and warm, and they've had a low-grade fever for a couple of days. What's the most likely diagnosis?
Sounds like a textbook case of localized acute bacterial lymphadenitis. It's really common in kids, especially in those cervical lymph nodes.
All right, so bacterial lymphadenitis it is. Next question. What are the 2 most common bacterial bad guys we should be thinking about in this scenario?
You're talking Staphylococcus aureus, including MRSA, and then good old Streptococcus pyogenes. Those are the ones we see causing trouble most often.
2 for 2, excellent.
Oh.
Okay, here's a tricky one, true or false. The WHO Aware guidelines recommend routine microbiology testing for all cases of localized acute bacterial lymphadenitis.
Ooh, that's a good one. But it's false. The Aware guidelines actually recommend against routine testing for most of these cases. Remember, watchful waiting is often the best approach, especially if the infection seems mild.
All right, you're on a roll.
Yeah.
Next up, what imaging method can help us get a good look at the lymph node and check for any abscess formation?
Well, an ultrasound is a great tool for that. It gives us a lot of information without being too invasive.
Awesome, last question. According to the AWARE guidelines, what's a typical duration of antibiotic treatment for uncomplicated localized acute bacterial lymphadenitis?
5 days usually does the trick.
Boom, you aced it. I knew you would disappoint.
Oh, thanks.
But seriously, folks, this little quiz just goes to show that you don't need to memorize every single detail to understand the key concepts. And speaking of key concepts, before we wrap up this deep dive, I'd love to get your expert perspective on the future of managing this condition. What are some of the challenges and exciting new developments we should be keeping an eye on?
One of the biggest challenges we're facing is antibiotic resistance. Those bacteria we talked about, Staphylococcus aureus and Streptococcus pyogenes, they're becoming more and more resistant to our first-line antibiotics. It's like a constant arms race.
That's pretty concerning.
Yeah.
What can we do to tackle this growing resistance?
Well, antibiotic stewardship is absolutely crucial. It's all about using antibiotics responsibly, making sure we're only using them when they're truly necessary, and making sure we're using the right drug for the right bug. And medical microbiologists like you guys are key players in this fight. You're the ones educating clinicians and promoting judicious antibiotic use.
Couldn't agree more. It's a team effort for sure.
Yeah.
Now, are there any other promising research avenues that you're particularly excited about?
One area that has me really intrigued is the development of rapid diagnostic tests. Imagine being able to identify the specific bacteria causing the lymphadenitis right there in the clinic. That would be a game changer for tailoring antibiotic treatment and reducing unnecessary use.
Wow, that would be incredible.
It would. And another area with huge potential is personalized medicine. Think genetic testing to figure out which patients are at higher risk of complications, or to determine the most effective antibiotic for a particular individual. It's all about moving towards more targeted, individualized care.
Sounds like the future of managing localized acute bacterial lymphadenitis is full of exciting possibilities.
It definitely is.
Any final words of wisdom for our listeners before we sign off?
My advice is simple. Stay curious, stay informed, and never stop learning. The world of infectious diseases is constantly evolving, so it's so important to keep up with the latest research and guidelines. And never forget, as medical microbiologists, you're vital members of the healthcare team. Your expertise is invaluable when it comes to identifying and managing these infections.
Those are some wise words. Couldn't have said it better myself. And to our fantastic listeners, thank you so much for joining us on this deep dive into the world of localized acute bacterial lymphadenitis. We hope you learned a thing or two and maybe even had a few aha moments along the way. Until next time, stay curious and keep exploring the amazing world of microbes.
I'm ready when you are.
All right, so let's put those brains to work and see what we've learned about localized acute bacterial lymphadenitis. Time for a little pop quiz, everybody. First question, we've got a 5-year-old child who comes in with a swollen, tender lymph node under their jaw. It's red and warm to the touch, and they've had a low-grade fever for a couple of days. What's the most likely diagnosis?
Based on that description, it really sounds like we're dealing with a classic case of localized acute bacterial lymphadenitis. It's incredibly common in children, especially those cervical lymph nodes.
Okay, so bacterial lymphadenitis it is. Next question. What are the 2 most common bacteria that we should be thinking about in this scenario?
Well, the usual suspects are Staphylococcus aureus, and that includes MRSA, of course. And then we can't forget about Streptococcus pyogenes. Those are the 2 that we see causing most of the trouble.
Excellent. You're 2 for 2. All right, here's a tricky one, true or false. The WHO-aware guidelines recommend routine microbiology testing for all cases of localized acute bacterial lymphadenitis.
That's a good one. But the answer is false. The AWARE guidelines actually advise against routine testing in most cases. Remember, watchful waiting is often the best approach, especially if the infection is mild.
That's right. You're on a roll. Okay, next question. What imaging modality can we use to get a clear picture of the lymph node and see if there's any abscess formation?
Ultrasound is a great option for that. It gives us a lot of useful information without being too invasive.
All right, last question. What is the typical duration of antibiotic treatment for uncomplicated, localized, acute bacterial lymphadenitis?
According to those AWARE guidelines, 5 days is usually enough to clear up the infection.
You aced the quiz.
Thanks, I tried my best.
You were fantastic. And to our listeners out there, this just goes to show you that you don't have to memorize every single detail to really grasp the key concepts. Speaking of key concepts, before we wrap up this deep dive, I'd love to get your take on the future of managing localized acute bacterial lymphadenitis. What are some of the challenges and what are some of the exciting new developments on the horizon?
Well, one of the biggest challenges we're up against is antibiotic resistance. Those bacteria we've been talking about, Staphylococcus aureus and Streptococcus pyogenes, they're becoming increasingly resistant to the antibiotics that we typically use as our first line of defense. It's a constant battle to stay ahead of them.
Wow, that is a little unsettling. What can we do to try and combat this growing resistance?
Well, antibiotic stewardship is really our most powerful weapon. We have to be really mindful about how we're using antibiotics, making sure that we're only using them when they're absolutely necessary, and making sure that we're using the right antibiotic for the specific bacteria that we're targeting. And medical microbiologists, like our listeners, play a huge role in this. You're the ones who are educating clinicians and advocating for responsible antibiotic use.
I completely agree. It really does take all of us working together. Now, what about other research avenues? Are there any promising developments in that area that you're excited about?
Oh, absolutely. One thing that I'm really excited about is the development of rapid diagnostic tests. Imagine being able to quickly identify the specific bacteria that's causing the lymphadenitis right there in the clinic. That would completely change the game. We could tailor our antibiotic treatment much more effectively, and we could really cut down on unnecessary antibiotic use.
That would be incredible.
It really would. And another area that I think holds a lot of promise is personalized medicine. Using things like genetic testing to figure out which patients are at a higher risk of complications, or to help us determine the most effective antibiotic for a specific individual. It's all about moving towards a more targeted and individualized approach to patient care.
Well, it sounds like the future of managing localized acute bacterial lymphadenitis is full of exciting possibilities. Any final words of wisdom for our listeners before we say goodbye?
My advice is to stay curious, stay informed, and never stop learning. This field is always changing. New research is coming out all the time. It's so important to keep up with the latest guidelines and best practices. And never forget that you, as medical microbiologists, are such an important part of a healthcare team. You play a crucial role in diagnosing and managing these infections.
That's some great advice, thank you. And to our amazing listeners, thank you so much for joining us on this deep dive into the world of localized acute bacterial lymphadenitis. We hope you learned some valuable information and maybe even had a few light bulb moments along the way. Until next time, stay curious and keep exploring the fascinating world of microbes.